Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/gbp. Supported by an independent educational grant from Al Milam.
Hello, my name is Rebecca Karpleaf, and I'm a classical hematologist at Mass General Hospital in Boston and co-founder and co-director of the MGH Porphyria Center. Welcome to this activity, One Disease, Many Clinical Presentations, Why and How to Spot Acute Hepatic Porphyria in Different Healthcare Settings. Before we dive into the upcoming micro-episodes exploring how AHP presents across different specialties, it's important to first understand why early diagnosis matters and how to test for AHP in everyday clinical practice. In this introduction, I'll walk you through the burden experienced by patients living with AHP and share practical tools to help you test for and identify these patients more effectively in clinic. So, these are the acute hepatic porphyrias, and it all boils down to heme biosynthesis. So heme biosynthesis is the process by which we make heme. 20% occurs in the liver and 80% in the bone marrow. And heme biosynthesis has 8 steps. And porphyria is when one has an error in one of those steps. And as a result, you get an obstruction or you get an overproduction. And you can have this buildup of heme precursors that can be toxic to many cells in the body. It's a multi-system disease and presents with multi-system manifestations. So AHP has complex and variable symptomatology. Approximately 90% of patients with symptomatic AHP are women. And over 90% of patients with AHP report severe acute abdominal pain during attacks. However, it's not just abdominal pain, and you can see here how multiple systems are affected, from the autonomic nervous system, the peripheral nervous system, central nervous system, and many other, including skin lesions, hyponatremia, and dark and reddish urine. So in AHP, misdiagnosis is the norm. And AHP may be mistaken for many other conditions, including those that cause chronic and severe abdominal pain, Guillain-Barré syndrome, other neuropathies, encephalopathies, psychiatric disorders, other porphyrias, and many others. And the time from onset of symptoms to diagnosis can be very long. So you can see here up to 15 years and even longer in some patients. So a simple spot urine test can accurately screen for AHP, and it's so important that you keep AHP in the differential diagnosis when you're seeing a patient. Effective treatments are available that can truly improve clinical outcomes for our patients. So please screen, and please think about AHP. So here is the Explore A and B studies that evaluated different but complementary AHP populations, patients with both acute attacks and those with chronic symptoms. So 88% of patients in Explore A, which included 112 patients overall, experienced acute attacks. And 77% of attacks required hospitalizations, ER visits, and heman treatment. And recurrent attacks were defined as greater than or equal to 3 per year. And then in terms of chronic symptoms in Explore B, 90% of patients had chronic symptoms. And this included 136 patients with AHP. And chronic symptoms included persistent pain and fatigue, nausea, neuropathy, and impairment in daily functioning. And so this underscores the fact that AHP is a chronic disease punctuated by acute attacks. So this is the POWER study, and it looked at patients with sporadic versus recurrent attacks. And you can see that in all groups, including those who received prophylactic treatment, there was an impairment in physical health, emotional health, cognitive health, financial, and social health, really across the board. Again, emphasizing the fact that we really have to do better in this patient population. And now, please answer this challenge question. So here is a diagnostic algorithm for identifying patients with AHP. And I can't overemphasize the importance of having a low threshold to test in patients who have symptoms that may be suggestive of acute hepatic porphyria. So here we start with symptoms suggestive of AHP. And the first step is to send a spot urine PBG. You can also include a urine ALA and urine porphyrins normalized to creatinine. And keep in mind that samples should be collected during acute attacks or when patients are having symptoms. This is the highest yield time. Again, measure creatinine at the same time as sending a sample for normalization of results. Some labs will do this, but oftentimes we just send a urine creatinine in addition to the porphyrin studies. Make sure to protect the urine sample from light. You may have to talk to your phlebotomists in the lab to make sure that they do this when they're shipping the sample. And really, a 24-hour urine collection is not necessary. A spot urine is all that you need. So if you identify a patient with significant elevation in urine PBG and ALA with symptoms, a diagnosis of AHP is confirmed. On the flip side, if a patient is having symptoms and their urine PBG and ALA are normal with these symptoms, AHP is excluded. And after you identify AHP based on biochemical testing, you can perform additional tests. So for instance, in patients with blistering skin lesions, I would recommend sending plasma porphyrins as they may be elevated, especially in patients with HCP and VP. And also perform genetic testing to help determine the subtype of AHP. So sequencing involves looking at 4 genes, so ALAD, HMBS, CPOX, and PPOX. And again, this genetic testing can differentiate the type of AHP that your patient has. And genetic testing can also be helpful in identifying family members at risk. And before we move on, please answer this additional challenge question. In AHP, there's a need for a multidisciplinary approach in care of these patients. So as we emphasized before, AHP is a multi-system condition, and oftentimes many medical specialties are involved, including hepatology, nephrology, hematology, genetics, OBGYN, neurology, dermatology, and of course, primary care. Now that we understand the importance of identifying AHP early and how to test patients, stay tuned as my colleagues will present real patient case scenarios and provide key clinical tools to help you recognize when to suspect AHP in different clinical settings. Thank you for watching.
Hello, my name is Miguel Bajoco, and I'm a psychiatrist at Coimbra University Hospital in Portugal. Welcome to this micro-episode, when it's more than migraine or mood, spotting AHP in your psychiatric presentations. Today, we'll discuss an important but often overlooked diagnosis in psychiatry, acute hepatic porphyria or AHP. Although AHP classically presents with abdominal pain and neurological symptoms, psychiatric manifestations may dominate the clinical picture. Patients may present with anxiety, depression, delirium, or psychosis, which can lead to misdiagnosis as a primary psychiatric disorder. This is critical, as many commonly used psychotropic and anti-epileptic medications can worsen attacks, resulting in recurrent episodes, reduced quality of life, and long-term complications. To illustrate how this unfolds in real-world psychiatry practice, we'll now review a representative clinical case. A 46-year-old woman was admitted to the psychiatric ward. The psychiatric history started at the age of 24 with a postpartum psychotic episode diagnosed as schizophrenia. Over the years, she had multiple psychiatric admissions, mainly for behavioral disturbances and suicide attempts, rather than persistent delusions or hallucinations. Her medical history included hypertension and epilepsy. At presentation, she showed mutism, minimal food intake, and altered behavior such as holding rigid poses. She was taking carbamazepine, ciomimazine, haloperidol long-acting injectable, and lisinopril. Initial laboratory tests showed mild anemia and mild elevations in liver enzymes and inflammatory markers. Brain CT revealed non-specific ischemic changes. The working diagnosis was acute psychiatric decompensation, and therefore alozapine was added. However, she developed worsening mutism, disorientation, and waxy flexibility. Treatment-resistant schizophrenia with catatonia was suspected, and electroconvulsive therapy was therefore initiated using thiopentatol anesthesia. After 8 ECT sessions, her condition deteriorated. She developed fluctuating consciousness, urinary incontinence, new onset abdominal pain, and sensory loss, resulting in accidental burns. Hyperpigmented skin lesions were noted on the soles and mucocutaneous areas. This constellation of psychiatric, neurologic, autonomic, and dermatological findings raised suspicion for a secondary organic cause. Importantly, thiopentatol can precipitate acute porphyria attacks. In addition, the Secondary Schizophrenia Index, or SSSI, was applied. The patient scored high on this index, which is designed to identify clinical features suggestive of secondary organic psychosis. A high SSI score significantly increased the suspicion that it was not primary schizophrenia, but an underlying medical condition requiring urgent metabolic investigation. At this point, metabolic testing was ordered. Urinary workup showed ALA was elevated, supporting the diagnosis of acute hepatic porphyria. This biochemical finding, together with the emerging neurovisual symptoms, abdominal pain, autonomic instability, sensory changes, and fluctuating consciousness, confirmed that it was not a primary psychiatric relapse, but a metabolic disorder presenting with preeminent psychiatric features. She was then transferred to internal medicine for specialized management. Retrospectively, her previous episodes may in fact have represented unrecognized porphyric attacks. And now, please answer this challenge question. In this case, psychotic symptoms may be directly caused by AHP, or they may reflect exacerbation of a pre-existing psychiatric disorder in the setting of a comorbid AHP. In psychiatric practice, AHP should be suspected when there are fluctuating or atypical psychiatric symptoms, poor or paradoxical response to treatment, recent biological triggers, or severe unexplained abdominal pain. Autonomic dysfunction, hyponatremia, peripheral neuropathy, and repeated emergency visits with negative investigations should also raise concern. If AHP is suspected, urgently test for urinary ALA and PBG. The key message is simple: do not miss this patient. Thank you for watching.
Hello, my name is David Kassiman. I'm an internist working at the Department of Gastroenterology Hepatology in the University Hospitals in Leuven in Belgium. Welcome to this micro episode, When Chronic Gastrointestinal Symptoms Hide a Rare Cause, in which patients should you suspect AHP? So most patients with acute porphyria, acute hepatic porphyria, don't present with a rare or specific symptom. They can present with recurrent abdominal pain, nausea, vomiting, fatigue, often without specific clinical, biochemical, or imaging abnormalities. So it's all non-specific. Because the symptoms overlap with everyday GI conditions, AHP is frequently missed or misattributed to disorders like IBS or non-specific abdominal pain, which delays diagnosis and, of course, also appropriate disease-specific care. To show how this happens in the real-world gastroenterology practice, we'll walk you through a representative patient case. So this is Lisa, a 20-year-old woman with recurrent abdominal pain, and she's in ER again with abdominal pain for a week, with nausea and vomiting. On physical exam, we have no clinical signs of peritonitis. In blood and urine, we have no inflammation, so normal CRP, normal lactate. The only thing we see is she has a bit of a hyponatremia of 123 with a low plasma osmolality, but a high urine osmolality and sodium, so it looks like SIADH. On imaging, she has had repetitive imaging. It was always negative, but this time she has a bit of a distended colon with constipation. So this is the timeline. She, in a period of 3 years, she had 12 admissions to ER, 3 gastroscopies, 2 colonoscopies, 3 CTs, and numerous ultrasounds. She had 21 lab workups, and she received a questionable diagnosis of acute right-sided colitis with normal colonoscopy, and she was treated with a porphyrinogenic antibiotic. In the end, the doctors in this other hospital refer her to psychiatry. She does not accept this, and she seeks second opinion in our university hospital, where she's seen by a senior colleague that tests her for systemic mastocytosis or tryptase, for hereditary angioedema, for lead intoxication, and of course for acute hepatic porphyria. And as you can see here, her spot urine PBG was 20 times upper limit of normal. And then the second tier testing, the enzyme activity, it was indeed reduced. Over the next years, you can see that she developed numerous acute attacks with PBGs going up to 800 no less. She was receiving hemin every other week. She was an addict to pethidine because we were giving it to her every other week. She lost her job. She went into a divorce. She couldn't take care of her kids. So major implications for her socioeconomic status and her quality of life. Could you please answer this challenge question now? So please, next time, don't miss this patient. It's a young female. The balance is 5 females to 1 male. She may have received new meds that could be porphyrinogenic, or hormone therapy like oral contraception or menopause therapy. She may have had an alcohol binge in the previous days, or she may have gone through weight loss over the previous weeks. In any case, she has excessive abdominal pain without inflammation, there is no lactate, and there are no signs of clinical peritonitis. She may have some hyponatremia, which looks like SIADH if you work it up. She may have neurological signs like paresis, polyneuropathy, a Press syndrome, or a Guillain-Barré presentation. She may have autonomic nervous system involvement like vomiting, nausea, diarrhea, constipation, tachycardia, hypertension. She very often will have psychological changes. In any case, she has disproportionate distress. There is a normal clinical exam. Imaging is negative. Your lab is negative, but she's in a lot of pain. And then she may have red or Bordeaux urine. Thank you for watching.
Hello, my name is Catherine Poshis, and I'm an obstetrician gynecologist and the director of complex family planning at Massachusetts General Hospital. Welcome to this micro episode, When Gynecologic Symptoms Signal Something More, Identifying AHP in Women's Health. AHP is an important diagnosis to consider in gynecology because it predominantly affects women of reproductive age, and attacks are often triggered by reproductive hormonal changes. Menstrual cycle changes, pregnancy, and hormonal contraceptives can precipitate symptoms, making gynecologic care a key point of recognition. Patients commonly present with recurrent severe abdominal pain, nausea, and psychological symptoms, yet diagnosis is frequently delayed due to overlap with more common conditions like endometriosis. To illustrate how this unfolds in a real-world practice, we will now review a representative clinical case. Our patient is a 24-year-old woman who was first referred to a tertiary care center for worsening blistering skin lesions and facial swelling that occurred after even brief sun exposure. Interestingly, her symptoms recently worsened after she changed from a levonorgestrel IUD to a combined oral contraceptive pill. Her medical history was unremarkable except for a history of headaches and a family history of skin sensitivity with a brother who also had sensitive skin in the sun and a mother who had a history of some blisters. This patient had lab testing that was notable for a mildly elevated ALT, and she also had a skin biopsy, which was concerning for Porphyria cutanea tarda. Going back to this patient's history, let's look at her timeline. She first had a 13.5 milligram levonorgestrel IUD placed in 2018 for contraception. The following year, she first started developing these blistering skin lesions on her hands and forearms, as well as a burning on her face and lips whenever she was in the sun for brief periods of time. She did While these skin lesions remain, she did overall well, but then in 2022, she presented to have her expired IUD removed with the plan to exchange it. Unfortunately, after removal of her IUD, her practitioner was unable to place a new IUD due to the patient's discomfort, and at this time, the patient opted to instead start a combined oral contraceptive pill with 20 micrograms of ethinyl estradiol and norethindrome. Shortly after that, she developed worsening skin lesions and presented to us in June 2022. So for our patient with her abnormal skin lesions that seemed related to her contraception, the diagnosis was unclear, but there was concern for possible AHP in the setting of the contraceptive relation. So she had blood and urine testing. Her spot urine testing was consistent with a diagnosis of AHP. She also had blood and stool testing, which confirmed her diagnosis of variegate porphyria, and genetic testing confirmed this mutation. So for our patient, her diagnosis of AHP was important because once it was recognized, we were able to change her management. She was stopped on her oral contraceptive pill and saw a marked improvement in her skin lesion within 2 weeks. She then opted to have a copper non-hormonal IUD placed for contraceptive and did well with it for several years. She then decided she wanted to grow her family, and after counseling with her reproductive team, had her IUD removed and had an uncomplicated pregnancy. Interestingly, she had complete resolution of her porphyria symptoms during her pregnancy and had a term delivery. This case highlights how an AHP diagnosis can directly inform contraceptive counseling, reproductive planning, and symptom management. And now, please answer this challenge question. In summary, don't miss this patient, a young female patient who presents with symptoms that are linked to hormonal changes either associated with her menstrual cycle or changes in her hormonal contraceptive or pregnancy. Symptoms that can flare after exposure to light, or patients who have severe cyclic abdominal pain, especially those who have a negative workup for other common gynecologic conditions like endometriosis. Thank you for watching.
Hello, my name is Paulo Serrano. I'm from Federal University of São Paulo, and I welcome you to this episode, which is called Beyond the Usual Suspects, Recognize Acute Hepatic Porphyria in Neurologic Presentations. Acute hepatic porphyria presents with acute and chronic neurological symptoms that may involve all the nervous system, include central and peripheral nervous system, and can resemble a primary neurological disorder. Although neurovisceral crisis may include abdominal pain, the presentation is variable, leading to delayed diagnosis and highlighting the importance of clinical suspicion and appropriate testing. To illustrate these events in real-world neurologic practice, we will walk through a patient case, which is a 35-year-old male that began with intermittent episodes of severe back pain that lead the patient to several visits to emergency department and did not resolve with dipyrone regularly. The clinical picture evolved in March 2020 with weakness in extending both wrists. The patient was not able to extend his hands, and the back pain worsened. The clinical picture of weakness in wrists resolved within 3 months with only analgesics. In February 2021, the patient had another episode with bilateral wrist drop, a treatment-resistant lower back pain, which progressed to the abdominal pain, which was very severe. So in the emergency department, they resolved to do exploratory laparotomy, which came back inconclusive, and the patients also had hyponatremia. He developed confusion, a delirium, and a flaccid paralysis in all limbs and was admitted to the ICU. His medical history was also very enlightening. He had irritable bowel syndrome since his teenage years, systemic arterial hypertension, insomnia, chronic back pain, and frequent periods of fasting due to his religious habits. The working diagnosis in the moment was Guillain-Barré syndrome. The patient was discharged from the ICU in a wheelchair. Took him 13 months for him to be able to walk again, but he remained with wrist drop. 1 year later, the patient still had the clinical picture of bilateral wrist drop, as seen in both pictures below. We conducted a lateral neuromyography, which depicted a chronic, severe sensory and motor axonal polyneuropathy in the forelimbs and worse in the hands. We must remember that Guillain-Barré syndrome is a demyelinating disease, not an axonal disorder. The working diagnosis at this moment was acute motor predominant axonal neuropathy. When we think of a flaccid paralysis, Guillain-Barré syndrome is a diagnosis we must think, but it's not the only cause. As we can see in that table, we see acute hepatic porphyria and heavy metal poisoning. And in this table, we have some clinical clues that shows clues to each cause, like episodic course is more typical of acute hepatic porphyria. Guillain-Barré is a monophasic disease. Abdominal pain is typical of acute hepatic porphyria, also of heavy metal poisoning. Acute flaccid paralysis is common in both Guillain-Barré and porphyria, and also can happen in heavy metal poisoning. Bilateral wrist drop is common of porphyria and typical of heavy metal poisoning, but does not occur in Guillain-Barré syndrome. And axonal polyneuropathy, I see in this case, is typical of porphyria and typical heavy metal, very rare in Guillain-Barré syndrome. And also hematological alteration is a typical clue for heavy metal poisoning. Do the clinical picture. We order a spot urine test, which came with elevated PBG and ALA. And we order a genetic test, which conclude the diagnosis of acute hepatic porphyria due to pathogenic variant in the HMBS gene, which causes acute intermittent porphyria. And now please answer this challenge question. Acute hepatic porphyria is a lot more than just abdominal pain. Hepatic porphyrias can cause various neurological manifestations, including central and peripheral neurological manifestations. It's not limited to an acute phase, as it may also cause persistent chronic symptoms that are frequently underestimated. Thank you for watching.
This has been an activity published by Peer Voice.